I am Professor Shahena Akter. Welcome you all to this 5 days long workshop on transvaginal sonography, colposcopy and hysteroscopy. We are very much enlightened that Dr. Sonal Panchal from Ahmedabad, India is along with us as a foreign faculty, but we have also grateful to Professor Rokeya Begum and Professor of Radiology, Professor Anisal Awal and Iddarul Alam. They are with us as local faculties in this workshop on transvaginal sonography on today. But there are, this program is designed as a lecture will be provided by Professor Dr. Sonal, and it will be followed by live demonstration of transvaginal sonography of different patients. It will be an interactive session. Everybody can participate with this hands-on training. Please cooperate with us and enjoy this session. Again, I welcome you all in this program. Assalamu alaikum. Thank you.
Assalamu alaikum. Honorable Principal, Head, Department of Obstetrics and Gynecology, Chittagong Medical College, Professor Dr. Shahena Akter Madam, our renowned gynecologist, Professor Rokeya Madam, and our prestigious guest, Dr. Sonal Panchal, and Professor Radiologist, and all my senior and junior colleagues, Assalamu alaikum, a very happy morning. So, I am Dr. Murtaza Begum, junior consultant, going to introduce today's our prestigious guest, Dr. Sonal Panchal Madam. She is actually a distinguished sonologist, renowned for her expertise in the field of diagnostic ultrasound imaging. She is an esteemed consultant sonography specialist at Dr. Nagori's Institute for Infertility and IVF in Ahmedabad, known for her profound expertise in ultrasound imaging, particularly in the fields of infertility and high-risk obstetrics. With an extensive educational background and a career dedicated to advancing ultrasound practices, Dr. Panchal stands out as a leader for her precision, dedication, and contributions to advancing ultrasound technology and practices. Dr. Panchal holds a PhD from the Sarajevo School of Science and Technology in Bosnia and Herzegovina, specializing in ultrasound in obstetrics and gynecology. She also earned a Master of Ultrasound in OB/GYN from the prestigious Ian Donald Inter-University School of Medical Ultrasound. Her medical degree in radiodiagnosis further solidifies her foundational knowledge and skills in medical imaging. As a professor at Dubrovnik International University in Croatia and a faculty member for Ian Donald Master's courses in ultrasound in OB/GYN and human reproduction, Dr. Panchal is dedicated to educating the next generation of medical professionals. She also serves as the National Academic Director for the Ian Donald School in India and is the Director of the Center of Excellence for the Ian Donald School Inter-University of Medical Ultrasound in India. Dr. Panchal has a specialized expertise in infertility, gynecological, and high-risk obstetric scans, utilizing advanced technologies such as Doppler and 3D, 4D ultrasound. She has trained over 800 doctors across India in ultrasound applications for gynecology and infertility and has been a faculty member for 3D, 4D ultrasound and infertility training programs both nationally and internationally. With a remarkable records of delivering more than 900 guest lectures at various state, national and international conferences, Dr. Panchal is a sought-after speaker and educator. Presented and published several papers at national and international conferences and in several journals. Her original research work on follicular monitoring, endometrial receptivity, and PCOS has been widely recognized and published in several prestigious journals. She is a National Advisory Board member for the International Journal of Infertility and Fetal Medicine, JIP publications, and a reviewer for the Journal of Human Reproductive Sciences. Regarding trainings, Dr. Panchal's commitment to continuous learning is evident through her advanced training in 3D 4D ultrasound from Professor Kratochwil in Vienna, fetal echocardiography from Professor Rabi Chaui in Berlin, and volume ultrasound in urogynecology from Professor Yang in Taiwan. She also conducts fellowships programs in ultrasound and infertility recognized by the Gujarat State University. With a career marked by excellence in clinical practice, education, and research, Dr. Sonal Panchal is a pioneering force in the field of ultrasonography. We are proud of you, ma'am. She dedicated to improving patient outcomes through innovative diagnostic techniques and comprehensive training programs. Book edited by Dr. Sonal Panchal, she has edited a significant number of books in the field of ultrasound and gynecology, highlighting key titles. Some of them are Ultrasound in Subfertility, Routine Applications and Diagnostic Challenges, Ultrasound for Congenital Fetal Anomalies, Ultrasound in Infertility and Gynecology, Text and Atlas, Donald School Textbook of Human Reproduction and Gynecology and Endocrinology, Handbook of Infertility and Ultrasound for Practice in Gynecologist, Practical Guide to 3D 4D Ultrasound in Obstetrics, Gynecology and Infertility, Practical Guide to Infertility Management and IVF, etc. Her contribution in books, Dr. Sonal Panchal's contribution to 146 books demonstrates her profound impact and expertise involvement in the field of ultrasound, gynecology and infertility. From editing authoritative text to providing chapters, her contributions have undoubtedly enriched the knowledge base of practitioners and researchers worldwide. With each contribution, Dr. Panchal has played a pivotal role in advancing medical ultrasounding and improving patient care in these critical areas of healthcare. Dr. Panchal's approach is characterized by a patient-centered philosophy, ensuring that each individual receives personalized care and attention. Her proficiency in using state-of-the-art ultrasound equipment, combined with her keen analytic abilities, allows her to detect and evaluate a broad spectrum of medical conditions with remarkable accuracy. As an advocate for continuous learning and innovation, Dr. Panchal remains at the forefront of advancement in ultrasonography. Thank you, madam. This is a so valuable and prestigious CV I have ever seen. Thank you, ma'am. Thank you all. So I am requesting sir to come over the stage and say something for our today's program. Sir, please.
Respected Principal, Chittagong Medical College, our guest speaker, Dr. Sonal Panchal, consultant sonography specialist at Dr. Nagori's Institute for Fertility and IVF, Ahmedabad, India, and my dear doctor present, Assalamu alaikum. We know that our workshop is going on from today on Transvaginal Sonography, Colposcopy and Hysteroscopy. We know that we can diagnose our vaginal or fallopian tube or gynecological so many diseases that we can, those who cannot diagnose in normal sonogram, we can diagnose through transvaginal sonography. already I discussed with Principal Madam, we have no transvaginal sonography machine yet and hysteroscopy machine. We will try to bring and contact with our Director General Medical Services to bring those machines so that our doctors will be benefited as well as our patient will be benefited. We know in Chittagong division, 4 crore people depends in this hospital. Our doctors learn and our a postgraduate student also, they'll be benefited if we bring such type of transvaginal sonography machine and hysteroscopy machine, as well as our patient will be benefited. I would like to thank Medical Education, Health, Manpower Development, DGME and Department of Obs and Gynae who organized today's workshop, which will continue for 5 days. I expect our doctors and also our postgraduate students, they will be benefited such type of organization. I will request Madam so that our CMS doctors, so that they can join today's workshop program. Yesterday I discussed with our CMS doctor, gynecological doctor. They told me, give me a invitation letter so that we can join in this program. You know, our military doctor, they cannot participate such type of program without DGFI clearance. It is better to send an invitation letter for our military doctors so that they can enrich their knowledge. But
You are the authority of this program.
okay.
This program is the program of Chittagong Medical College Hospital. So you can invite them for to attend these sessions.
Okay, thank you, madam. I will tell them so that they can organize from today till finish this program. Okay. Thank you, madam. I hope our workshop will be very successful and fruitful, and we learn so many things, and we will enrich our knowledge through such type of workshop. Thank you, madam.
Thank you, sir. Now, I would like to request Professor Rokeya Madam to say something regarding this program. Madam was so much curious. So, Madam, please.
Thank you, Ranu. Ranu is doing lot of job for organizing this workshop. First of all, thanks to Sonal. I know him from last 20 years. Every conference and seminar, there is a Sonal give a lecture on different type of sonography lecture by Sonal. She is so dedicated and so laborious. She is running from Ahmedabad to Chittagong in a 1 day, and everybody like my junior colleague follow Sonal, how she is active, laborious and dedicated, and to give good educationalist to teach the student. That is necessary for us to build up the nation. And thanks to the Bangladesh government health ministry to organize such this workshop and give a facility to come to Sonal to Bangladesh. Thank you.
Thank you, Madam. Now, I would like to request our prestigious guest, Dr. Sonal Panchal. Ma'am, everyone please be ready and attentive. Ma'am, please deliver your lecture. We are eagerly waiting for your lecture and wish a happy learning. Thank you.
Thank you, Brenda. Good morning, all. And it is indeed, I cannot express my excitement and my joy that I am here today with you all. My sincere thanks first to Professor Rokeya Begum, very close friend, and she is instrumental in bringing me here. Thanking very much Dr. Famida for facilitating everything for me, starting from my tickets. She booked my tickets. We had to cancel the tickets because it was all a lot of chaos in that. We booked again, and she's always been after me for all my anxieties and for all my stresses that I had before I came here. And thanks to Dr. Ranu also, who spent 2 hours of hers at the airport for me, waiting for me. So let's start right away without wasting any time on other formalities. Thank you very much, and it's my honor, sir, madam, to have you here, Director, sir, and Professor of Radiology, sir, here. So it's an honor, and a lot of other senior people who are here. So it's truly an honor and a respect to me, sir. So let's start right away with the session. And I know that, I mean, I've just come to know from what Director Sir was talking, probably transvaginal scans are not very easily available here. And I also believe that maybe it is because of that even your female patients are not ready for transvaginal scans. I mean, they're not absolutely always ready for the transvaginal scan, but believe me, transvaginal scan is one modality which gives you maximum information in a single non-invasive test. So mastering transvaginal sonography is not mastering a different art. It is just acquiring your own fingers with some extra abilities. And those extra abilities are much more probably than any other investigations or tests that you do. Moreover, it's non-invasive. So it's something which is worth mastering. So, no, I've not changed. Slide is there only. I mean, they have to start. My projector. No, they are all set also. It's there. It is there, madam. Okay, so let's truly learn the transvaginal scan systematically. When we do an obstetric scan, most of us, if we are doing obstetric scans, we have gone and learned somewhere as to what is the correct biparietal section, what is the correct abdominal section, and so on. But when it comes to transvaginal ultrasound, that's when, unfortunately, no systematic training is available, and therefore there is always a confusion in transvaginal sonography, not only about the pathology, but sometimes also about the laterality, whether it's right or left, whether it is anterior or posterior, and so on. Yes, it is true that when you want to assess the pelvic structures, that is when, can we switch on this fan, or it is not possible? Or maybe that AC, because it is too hot over here. So when we want to assess the pelvic structures, the uterus, ovaries, and the tubes, and the adnexa, and so on, that is when we need, we can approach it either by a transabdominal scan, we can look at it by the transvaginal scan, or we can do a transrectal scan. Though transrectal scan is very sparingly used, it's been used only for those patients in whom you need to see and assess the pelvic organs very closely, but unfortunately the vaginal route is not available, maybe because the patient is virgin or she has a severe vaginismus. Excuse me, sirs. Please finish that quick and so that we can start. it is okay if it doesn't work. Don't matter. Don't mind. It's okay. I'll manage. But if we are all settled, probably you will be able to gain everything that I'm speaking. Otherwise, I'll also lose my tempo. So. Are we all set? Thank you. Should I start? Yes. So that means that transrectal scan is very rarely done, but it can be done as simply as you do a transvaginal scan, but always prefer a transvaginal for all your fertility scans at least. Transabdominal route. Yes, it is true that every book writes that before starting a transvaginal scan, you must do an abdominal scan, and I don't disagree to that at all. But as a gynecologist, we are more capable of understanding the anatomy, the vaginal route. It is a slight, I would say, it is a little difficult for a radiologist to understand the anatomy of the pelvic anatomy, the vaginal route, because it is the abdominal route that has been taught. Not that nobody can do it. A lot of people can do it, but you have to clearly understand the anatomy the vaginal way. But that is a boon to the gynecologist, because we have learned the anatomy that way. And therefore, what I do for my patients is that if I am doing a transvaginal scan, and if I can not see all the margins of the uterus and the ovaries or lesions arising out of that completely on my vaginal scan, I will definitely do an abdominal scan. You can follow any of the two techniques. You can either do abdominal scan for all, or you can start with vaginal and if required do an abdominal scan. But whenever you do an abdominal scan, there are a few things important. You know that because the pelvic organs are quite far from the probe that you place abdominally, therefore you will always have a poor resolution of the uterus and the ovaries, and therefore a lots of details about the ovarian anatomy especially can be missed when you are doing an abdominal scan. So doing a scan for pelvic organs abdominally, or even small fibroids and lesions of the uterus, or even sometimes the endometrial morphology may not be in detail studied. When, of course, we do it with a full bladder, but still, when we have a problem finding out the uterus or the ovaries on the abdominal scan, that is when it is essential that you would press the probe and bring the probe as close to the So you should place the probe. When you place it on the abdomen, that's when it is essential. You don't just press like that posteriorly. You have to always angulate it towards the inlet of the pelvis, and that is an important technique as it is clearly shown here in the image. So you press the probe towards the inlet, angulate it and press it towards the inlet so that you can see the uterus and the ovaries better. When we are doing a trans-abdominal scan, that is when the orientation of the image is not at all difficult, because we all know that we have put the probe here, which is on the abdominal wall. So this is the interior aspect of the patient, and this is the far end, so that is the posterior aspect of the patient. Remember, whenever you are doing a scan, you know that the probe has a marker. Do you know the probe has a marker? And that marker always correlates with this logo here. Whichever brand machine you are using, the logo correlates with the marker. That means that when you start your scan, always your probe
should be towards the head of the patient. You cannot just place the probe anyway. In the longitudinal probe position, the marker of the probe should always face the head of the patient, and if that is the case, that is when, because the logo is here, therefore this is the cephalic end of the patient and that is the caudal end of the patient. Very importantly, when you, is my voice consistently coming? It's okay. When you want to do a transverse scan, that is when it is essential that you always rotate your probe 90-degree anti-clockwise. You have to rotate your probe 90-degree anti-clockwise, because when you rotate it anti-clockwise, that's when the marker which was facing the head of the patient is now on the right side of the patient. And the logo also on the transverse section is on the right side. So the right side of the patient is, right side on the image is the right side of the patient, and left side on the image is the left side of the patient. There is probably a erroneous concept if people would rotate it on the right side for the right ovary and on the left side for the left ovary. Remember, once you have rotated the probe, or even if you have not rotated the probe, if you want to see the structures on the right side, you should span the probe or angulate it on the right side. If you want to see the left, you have to span the probe on the left side and angulate it on the left side. So the rotation for the transverse section is always anti-clockwise. You can see the right ovary or the left ovary depending on you have spanned and angulated on the right side or on the left side. So that is important about the transabdominal scan. Coming to the transvaginal scan, of course, you all know that we do it with an empty bladder. You know that we would always counsel with the patient. We will inform her what we are going to do, and we will take her verbal permission, and then we will do a scan. As you introduce the probe, so even before you introduce the probe, the first important thing is that the position of the patient is very important. If you try to do a pelvic scan, a transvaginal scan on a flat bed, don't expect great miracles, because when you are using a flat bed, even if the patient is in a lithotomy-like position, there is no place for your probe to move. And therefore, you can not approach absolute anterior structures, or sometimes even you would have difficulty into moving your probe onto right and left. So remember, as a rule, transvaginal scans must be done on either a gynae couch, or it should be a dedicated bed designed like this, where, of course, like the gynae couch, it has a notch there for the buttocks, but it should have long foot arms. When there are long foot arms, that is when the patient can slide right up to the edge of the notch and still rest her feet and bend her knees completely, and you have a lot of space there to move your probe, and you will not have a difficulty. So that is one very basic thing that we need to always understand and follow. You don't need a separate bed for obstetric scans, so don't think you have to have two examination beds. This, if you can see, has a long length. So what we do is, if the patient is on a transvaginal scan, her head will be somewhere here, but if it is an obstetric scan, we will allow her to slide up, and she can put her two lower limbs straight on the 2-foot rest. So that is about the position of the patient, which is very important. Then introducing the probe is a second problem. Many a times, it is quite a resistance before you can introduce the probe. And if that is the case, what needs to be done? The first thing, ask the patient to breathe out forcefully. Full expiration, not blowing. No, not that. And when that happens, all the 3 orifices relax, and your probe can slide inside the vagina through the introitus very smoothly. Don't ever screw in the probe, because even when you are doing a vaginal scan, that is also when the probe, the marker on the probe always has to remain facing the anterior aspect of the patient, so facing the roof. If you screw in the probe, you don't know where that marker went. So it is always important that gently gently slide the probe inside through the introitus when the patient expirates out. If that does not help, and you still have to exert some pressure, don't exert the pressure inside like this on the introitus. Press posteriorly on the anus. That will immediately make the vagina more spacious, and it will be easy to introduce the probe through the introitus. Rarely will you need to do any other maneuver like folding the thighs completely on the abdomen to allow a more space into the vagina. So those are the important practical clues which we need to follow when we are doing a vaginal scan. Then coming to the next thing, and that is the probe movement. Remember that even when you're doing a transvaginal scan, every movement of the probe is going to irritate the patient. It may cause pain or may cause irritation. anterior muscularis. As you gently introduce the probe, you can see the splaying of the anterior and the posterior vaginal walls, and you can now also appreciate clearly the interface between the vagina and the bowel. So you should introduce the probe inside, come back once, go again in. If you are not sure about the free sliding movements between these tissue layers, that's when you will have to do an additional maneuver to evaluate the posterior compartment. If the sliding movement is not there, that means there is some adhesion. If there is some adhesion, it may be the commonest deep infiltrating endometriosis. It may be inflammation, post-inflammatory. It may be post-operative. So it means there are adhesions between the tissue layers, and you need to find out the cause. As you gently introduce the probe then inside, you will touch the cervix, and as you touch the cervix, you are seeing fluid in the cervical, in the vaginal cavity. You are seeing the thin vaginal wall here. You are seeing the peritoneum over the vagina. You are seeing here the posterior lip of the cervix and the anterior lip of the cervix and the cervical canal. Gradually go in, and that is when you would see the uterus. Yes, so that is the information about the vagina, about the cervix. Many times we come across cases where patients say, oh, this reminds me, just last week we had one patient who got an MRI of the pelvis done. Why? Because the Bartholin cyst was not seen on ultrasound. That is not possible ever. If you don't introduce the probe correctly, you will not see it, but otherwise it's not possible that you have not seen it. So it is very essential to do this scan very carefully, and as you introduce the probe, you must always keep on looking at the scan. Now if you look at this scan, if I've introduced the probe inside and I'm not seeing, as I told you, I'm not seeing any part of the mid-sagittal plane, right? And the moment I span this probe, I will see the mid-sagittal plane. That tells me the uterus is deviated. So that's what I meant to tell you when I said that you can identify whether it's a deviated uterus or it is a twisted uterus. Now, even if it is a deviated uterus, first find out the mid-sagittal plane of the uterus, and once you have found out the mid-sagittal plane of the uterus, that is when you would then span across the uterus from one side to the other side and evaluate the smoothness of the serosal contour. You would check both the myometrial walls. Both have to be almost equal in thickness and isoechoic. You would always have to check the junctional zone, the endometrio-myometrial junction, which is an hypoechoic area surrounding the endometrium. And you would also go to the endometrium to check not only the shape of the endometrium, but also the central line. The smoothness of the central line is important, because many a times you may have small polyps and they would only show irregularity of the central line. They are so small that and subtle in echogenicity that you will not be able to otherwise identify them. But because you are seeing that central line irregularity, you can put on a Doppler and you will know that yes, there is probably some pathology here and there. Then once you have introduced the probe and you have finished assessing the uterus, angulate your probe towards the cervix. The cervix in an anteverted, anti-flexed uterus is posterior. So angulate your probe slightly posteriorly, and when you do that, that is when you will see the cervix. Once you see the cervix, always pull out the probe a little. When you pull out the probe, see, you can see both the lips clearly, you can see the canal also clearly. So your cervical polyps cannot be missed then. And once you have finished doing that, and evaluated the cervix, you can go and check the mobility. If I say evaluate the cervix, it is not only for the pathologist, it is also to find out whether the cause of infertility is cervical or it is something else. Because, and the second important thing is, you always need to find out the cervical length if you are going to do IUIs, the semen sample needs to be released in the endometrial cavity and not close to the fundus, because when you go close to the fundus, it is a possibility that your entire sample would flow into one of the tubes. So you should always release it in the endometrial cavity, and therefore you need to know the cervical length, and the length of the IUI cannula that you will introduce will be 1.5 centimeters plus the cervical length beyond the external os. So how will you measure the cervical length? You have to identify the internal os and the external os. The external os is beautifully seen there. There is no problem at all. You are seeing the vaginal wall, you are seeing the fluid, and you are seeing the external os. But the internal os is to be identified by the presence of the cervical glands. As a gynecologist, you would think we would find out the uterine vessels, but uterine vessels are not in the mid-sagittal plane that you are doing a scan in. The curvature of the uterus is always not present. It may be straight also, so that is also not an identifying point. Sometimes you may be able to find out the level of the bladder peritoneal reflection and would say, but that is also always not easy. But you can always identify the internal os by the cervical glands. You all know that cervical glands are the structures which are present in the cervix, not in the uterus ever. And the cervical glands can always be seen as a separate, subtly different echogenicity and a very thin hypoechoic line between the musculature of the cervix and the cervical glands. So identify those cervical glands and see this tapers here. Yes, so that is the internal os, and measure the cervical length. For obstetrics, we are taught to measure the cervical length by the straight line. For infertility, we are going to measure it as a curved line always. So measure the cervical length, and we would be done with that. But there is something very important and interesting. If I told you that cervical glands assessment would tell you whether the cause of infertility is cervical or not, very interestingly, the cervical glands in all other phases of the cycle, they are hypoechoic. As you can see here also, it is hypoechoic. I'm sorry. You can see here it is hypoechoic. Yes, but in the periovulatory phase, it is always hyperechoic. So if the cervical glands turn hyperechoic in the periovulatory phase, that means there is sufficient secretion, there is sufficient effect of estrogen on the cervix, and therefore most likely it's not going to be a cervical factor in fertility. Check by in and out movement of the probe for the mobility of the uterus, and also check for the mobility of the cervix. Look at the bowel movements around the fundus and look at the bowel movements around the cervix also. Having done that, now you would move to the transverse section. Remember, when you move to the transverse section, always bring the uterus fundus in the center and only then rotate the probe, because only when the fundus of the uterus is in the center, when you rotate the probe here, you will be cutting in the center. So ideally this is also not the position. The fundus should be seen here, and then you rotate the probe. And that can be done by anterior angulation if it is an anteverted uterus, that can be done by posterior angulation if it's a retroverted uterus. And then rotate the probe 90 degree anticlockwise, and that would give you a transverse section. And on the transverse section, again I repeat, right side, left side, anterior and posterior aspect of the patient butt. That is anterior and posterior aspect of the patient. Which wall of the uterus is this? If it is an anteverted uterus, it is an anterior wall. If it is a retroverted uterus, it is a posterior wall. Yes, so that is about the transverse section orientation. Now, once you have gone to the transverse section, you would do an up and down movement of the probe to span to evaluate the uterus in the transverse section. As you go towards the fundus, you can see here splaying of the two cornu, which tells you two cornu are present. You can also see in that so-called semicoronal section, there is a smoothness of the fundus, which even without your 3D rules out a possibility of duplication abnormality. And it also rules out the possibility of unicornate uterus because you are seeing the two cornu there. And then span your probe down to the cervix, and that finishes your survey of the uterus. Having done that, quickly looking at the measurements, we would do this on the live also, but the measurements, if I say, it is always to be measured as a curved line when the entire uterus is seen. This is the anatomical uterocervical length, not practically important to us unless we have to diagnose hypoplasia. Then the second is measuring the effective endometrial length or the endometrial trace, which is from the fundal end of the endometrium to the external os. And then to measure the endometrial thickness and to measure the AP thickness of the uterus, the fundus needs to be brought into the center, and then you measure the AP diameter, the widest, the highest thickness of the uterus anteroposteriorly, but perpendicular to the central line always. And even the endometrium is measured as outer margin of the hyperechoic line to the outer margin of the hyperechoic line, and always perpendicular to the central line. So that's how you are going to measure the endometrial thickness. And on the transverse section, measure only the transverse diameter. Never measure the AP diameter or the endometrial thickness on that. Having done that, now we have to trace the ovary. If the ovaries are placed just by the side of the uterus, as we saw here in this image, we feel we are blessed, but I don't feel we are blessed, because when the ovaries are placed that close to the ovary or that close to the uterus, that's when you can actually not evaluate the soft tissue adnexal band, which consists of tube, ligaments, and vessels. Why is it important for me to look at this soft tissue adnexal band is because it is this band, the soft tissue adnexal band, which you're seeing here. If I said it contains tube, ligaments, and vessels, tube may get inflamed, and acute salpingitis, which is almost always missed, can be diagnosed if you make a routine habit to check this soft tissue adnexal band. If the thickness is more than 1 centimeter, and if you see vessels which are running across, this normally also contains vessels which run from uterus to the ovary or ovary to the uterus. But if you see vessels running across in a low velocity, low resistance flow, it tells you it is acute salpingitis. When you suspect acute salpingitis, if you press on probe pressure, patient will complain of pain. Sometimes there will also be free fluid. And if you get a chance, also go and see the ovary. Even if you have not seen the ovary of that patient earlier, if you compare the echogenicity of the stroma of this ovary with the echogenicity of the myometrium, the echogenicity of the stroma will appear low, and if you put on the Doppler, there will be a lot of blood flow inside, which tells you there is oophorytis also. Oophorytis and salpingitis you would otherwise not even think of diagnosing, but this is a very easy and a simple way. If you do a proper transvaginal scan, you can do it. So one is just by the side of the ovary, second is by tracing the soft tissue. See, you are seeing beautifully the soft tissue adnexal band here, and that leads you to the ovary. So that is the second way. If these two are the not the positions of the ovary, and here this is an inflamed tube, you are seeing that there is fluid surrounding, the band is thickened. You are also seeing that the ovary shows multiple small follicles only, and it is a hypoechoic stroma. So that tells you it is probably an oophorytis, and in all these cases it would be pain on probe pressure. If you don't find, sorry, you have to measure. You have to measure more than 1 centimeter, as I said. Now, if you, these are the two positions. I said one just by the side of the uterus. Second, we said tracing the soft tissue adnexal band. If you don't find ovary in these two positions, just angulate your probe posteriorly. Most likely the ovaries will be placed posterior to the uterus. And if that is also not the case, then span the probe right up to the lateral pelvic wall. As you go to the lateral pelvic wall, you would see two large vessels in long axis. These are the iliacs. From there, if you angulate the probe supromedially, you will see the ovary. This is the normal ovarian fossa. If you don't see the ovary in these 4 positions, that means the ovary is surely grossly displaced. Move your probe right up to the lateral pelvic wall. Span it up and down, absolutely up and down as you move from lateral to medial, till you reach the lateral margin of the uterus, and you'll find the ovary somewhere. And if you find the ovary there, again check the mobility of that ovary like you would check for the mobility elsewhere also. But when it is a grossly anteriorly or a grossly posteriorly placed ovary, if it is not fixed, it may have a long ovarian ligament, and these are the patients when you stimulate, you have to be very careful. They may result into torsion. If they are fixed, they may be a result of endometriosis or surgery or maybe inflammation. Locate the ovary, rotate your probe, find out the longest axis of the ovary and the longest section, and freeze it on one of the frames of the dual frame image with the ovary in the center of the image. It should not be on the side. And once it is in the center of the image and you have taken the longest section, only rotate your probe 90° anticlockwise, do no other movement, and that will give you the transverse section of the ovary. Measure the longest diameter, measure the longest diameter perpendicular to the long diameter, and measure the longest transverse diameter parallel to the x-axis. These 3 will calculate the ovarian volume for you. Having done that, we would check for the mobility of the ovary also. You can see here bowel moving on the ovary. Here you can see the bowel, ovary and the uterus are side by side. You can see the bowel moving there, but you don't change the relationship between the uterus and the ovary when you press. That means the ovary is adherent to the uterus. What is very important, and then lastly, see the pouch of Douglas for not only fluid but any other pathology that you would see also. You would hope to see because of the clinical history of the patient, and then you would move to the Dopplers. But Dopplers we will do with the individual cycle assessment lectures. Evaluate the ovary by spanning across for any of the lesions. Check for any extra ovarian lesions also. As you can see here, there is a large hydrosalpinx with, this is also hydrosalpinx with a waist sign here. Waist sign is what? There is a narrowing in that cystic area. So you would see 2 parts of the cystic area with a narrowed area in between, which tells you it's a waist sign, which is because of the hostra. We will see on the live if we have, but or maybe in some other presentation. We don't want to spend time here. So check for any extra ovarian lesions, and that is it. What is important to remember? Never ever exert any pressure, undue pressure when you are doing transvaginal scan, because everything that we are seeing is a soft tissue. It can get D-shaped, it will lead to pain, will not allow you an optimal assessment. Even if the mic is not working. Hello? Yeah? Okay. So, it can get D-shaped and it can not do, it will not allow you to do an optimal assessment. Even if you cannot see the ovary, press the probe inside a little dip into one of the lateral fornices to see the ovary, but and if required, press with the other hand on the abdomen. But once you have located it, just take off the pressure a little. Don't remove the probe, but take off the pressure a little so that you can evaluate it without pressure. Whatever you see always must be seen in 2 anatomical planes at least, the longitudinal and the transverse. A dynamic examination to check the mobility, to check the pain on probe pressure is very, very important. Doppler is very important because Doppler helps you to differentiate lesions very, very beautifully and also assess the aggressiveness of the lesions. Understand the entire anatomy, and if possible, try to make a diagram, a pencil diagram of what you have seen. Correlate everything that you see with physiology, because we know that ovary is otherwise also a host to several cystic lesions, which is a normal thing, And therefore, no, don't always think of pathologies. First think of physiology. If it doesn't set into physiology, only then talk of a pathology. If you are finding lesions which clearly don't appear malignant in the ovary also, make a habit to always reassess them after 2 or 3 weeks, rather than stamping a diagnosis, being in a hurry of stamping the diagnosis or getting a CT or an MR done. And always remember, there are lots of incidental findings that you would find when you're doing a transvaginal scan. Not that you don't have to mention it, you have to mention them all, but also mention whether they appear to be the cause of this patient's symptoms or not. So that is about, need to know about the machine. Yes, I've written as Doppler basics, but it is not truly Doppler basics only. The first thing is that why do you need a Doppler? Where ultrasound, 2D ultrasound tells you only about the anatomy of the uterus, pelvis, uterus, ovaries, whatever. It is Doppler which tells about the functional status of the follicle, of the corpus luteum, of the endometrium, and so on, because we know that menstrual cycle, which is a continuously changing, very well balanced orchestra of multiple hormones, it is this hormonal changes which reflect immediately into the hormone, the vascular changes, and these changes can be diagnosed by Doppler. Therefore, if you do the Doppler and if you can interpret it correctly, it would tell you about the instant hormonal status. And in countries like yours and mine, where not all people are affording, not all fertility treatments are insurance or not repaid by the government, that's where we have to opt for lower cost treatment and still effective treatment. And even if you do a hormonal test, you are still going to do an ultrasound. So why not just add a Doppler to it and interpret it correctly so that you can avoid a whole lot of hormonal investigations. And when I say that, I know that most of you will be not believing it or get astonished when I say that though we are a dedicated infertility institute with very high results, of course on IVF, but even better results on IUI, which is a low cost treatment, as you all know. We have about more than 17,000 pregnancies by now with IUI. I'm not talking about IVF. IVF is separate. And at least about 200 plus cases where 3 or more IVF failures have conceived with IUI or with natural intercourse after treating the males. In spite of seeing so many patients, we do not do any hormonal investigations, and that's what we are going to correlate it with when we talk about the sonoendocrinology also. We don't do any FSH, LH, AMH, androgen, estrogen, progesterone. The only 3 investigations that we do is prolactin, thyroid, and insulin resistance, and that is it. You don't need to do anything else, because when we do the test, we don't want the exact numbers. What we want is whether the level is high or low, is too high or it is too low. And that can be easily judged on your ultrasound, and that is why Doppler has a very important role to play. Of course, I know that we are all clinicians. We don't want to do any physics at all, but if we want to do a correct interpretation, we definitely require a good quality image. And to get a good quality image and a high frame rate, there are a few adjustments which we need to learn. I will not tell you what is a good quality or a good resolution image, because you all know that, we are all using mobile phones. We all select our mobile phones by the camera pixels, and we all know that more pixels is better resolution, less pixels per unit area is a poor resolution, and so on. So we want good resolution. The second important thing, which if I said frame rate, we know we are doing a real-time ultrasound. If you are doing a real-time ultrasound, that is when it is multiple 2D images which are coming one after the other fast, and if we compromise a little on resolution, maybe we can have a better frame rate. Whereas if we are having a very sharp image, we may have a little lower frame rate. But for every image, we have to decide, is the dynamicity important? Is the 2D image important? And accordingly, we may be changing from the resolution to the frame rate. And that is not a very difficult task if I tell you. There are just a few adjustments and a few knobs we need to know. We are using ultrasound machines, but we are not used to touch these knobs. We would only keep on working with the settings that are done by the application specialist. That is why n number of times it happens that we would see images, the images that may be produced would appear something like this. Something like this, yes, wherein the uterus, which is the area of interest, is covered only in the upper third of the image, and the rest of the information that goes to the scanner is absolutely useless. So the first important thing is that as soon as, no it's not zoom, as soon as you switch on your machine, the first thing you would start your scan, the first thing you would do is you would open the angle of the scanner, of the probe completely, see as wide as you can, take a longitudinal survey of the uterus, then rotate the probe 90 degree, get a complete view of the pelvis, the pelvic anatomy, locate the structures that are of your interest, and then first thing you will do is you will bring the area of interest right in the center as you are seeing here, and you will decrease the scanning angle. Because you decrease the scanning angle, the unnecessary information going to the machine will decrease and the frame rate will improve, and even the visibility will be improved, because the reason is that the structures that you bring in the center of the image, the sound beam that hits it is completely reflected, whereas the structures which are at the side, usually what happens, if your angle is completely open and you are seeing the ovary there on the side, you will be satisfied, okay, I've seen it. But that doesn't give you an optimal view. You have to bring the ovary in the center, and when you bring it in the center, because the sound beam is hitting it perpendicularly, you are going, and the entire beam is going to reflect, you will have a much more clearer picture of the ovary, of the endometrium and so on. You know that the structures which are at the side, the sound beam will hit it, but it refracts more than reflects, and therefore the margins will not be clear. So first thing is setting the angle. The second important thing is setting the depth. The correct depth adjustment would be when the area of interest, so not this, but when the area of interest fills up at least 2/3 of the image. The area of interest, when it covers at least 2/3 of the image, this is the correct depth setting that would improve not only the frame rate, it would also improve the resolution, because the same number of pixels that you were using to see a 10 centimeter depth, now you are using only for 4 centimeter depth, and therefore the image visibility, the clarity of the image, the resolution is going to be always better. These pictures I've put here. If at all you don't find where to adjust this on your machines, this will be the symbol which will indicate the depth. Angle will be written as angle most of the times, or it would be a box with 2 dashed lines and an arrow down there, which will tell you this is the knob by which I can adjust the angle. The third important setting is what is called focal zone. When you do an ultrasound, you have a tiny triangular head, arrowhead, and this is what is, so you probably will see here better. Just a minute. Yeah, you are seeing here. Just 1 minute. You are seeing it here. You are seeing it here. So that is a tiny arrowhead that you see. It is called a focal zone. Electronically, the ultrasound beam is so treated that it gets narrowest at that level. Because it gets narrowest at that level, there is least of refraction, more of reflection. Image quality is the clearest there. So I always adjust the focal zone at the level of area of your interest. Moreover, the adjustment of the focal zone is also required, because all the other settings that you would do will reflect most on the focal zone, not on the other areas, but most on the focal zone. Therefore, it is very essential that you would always set the focal zone at the area of interest. If you sometimes have to see structures like this, where you are interested in the entire depth, that is when you can increase the number of focal zones. As you can see here, instead of 1 focal zone, there are 3 focal zones here. But look at this. Look at both the images where the probe movement is the same, but here the frame rate is much higher as compared to here,
which means that when you use more focal zones, that's when the frame rate is going to be decreased significantly,
and therefore make a habit not to work with multiple focal zones. Only when required you can switch on to multiple, go back to the single focal zone. Zoom is very important, but
most of the times we unfortunately take a shortcut and we zoom the image like this. Here we are only separating the pixels. We are not zooming the image, we are only changing the visibility. And this is what should not be done when you're doing active scans. It decreases the quality of the image, but you should always use what is called a box zoom. And the box zoom or the HD zoom is when you select a box and you zoom only that much area. You're not compromising on the frame rate, you're not compromising on the image resolution, and you get a high quality image with a better visibility and a better resolution. But remember that when you are doing a live scan, you need to use an HD zoom or a box zoom. But if you have already frozen the image or you have stored the image, that means you have already fixed the quality of the image. Now you can use a pan zoom. So when you just rotate the probe and you blow up the image, it is pan zoom. When you put box and then you enlarge only that much portion, it is called an HD zoom. So HD zoom for the live scans, pan zoom only for the stored or the frozen images. I have not talked about gains. I have not talked about contrast positively, because I don't want you to touch gains and contrast as far as possible. Contrast, please don't ever touch it once it is adjusted according to your eye training. So you have set with the application person when she comes to set the machine, and you have adjusted the contrast and the gray map the way you want to. Now don't keep on touching it. Gains ideally should not be touched, but if required and if you touch the gains is only to, remember, it is only to improve the visibility, it is not to improve the resolution. Doesn't improve the image quality, on the contrary deteriorates it, because too bright and too dark, both the images would give you fall or deterioration in the soft tissue details. So once your gains are adjusted, please don't keep on changing it. But if at all you still have to, after doing all the other adjustments that I talked about, if you still have to, that is when you may change the gains, you may examine the structure that you want to, but the moment you move out of that scanning field, again go back to your preset, because when you do a gynec scan, you're looking at cystic lesions which appear very similar to each other. Say for example a follicle, a luteinized unruptured follicle, a corpus luteum. And if your gains are not correct, a corpus luteum would look like a follicle and a follicle may look like a luteinized unruptured follicle. So be very careful, don't keep on changing the gains. Having done that, now we move to the color things. And for the color, I think the basics most of you know, or if I need to tell you in a very short, color Doppler, where you see two colors, you are seeing two colors because it tells you the direction of the flow. The flow which is towards the probe usually appears red, flow which is away from the probe usually appears blue, but you can invert it. So don't always get carried away. Moreover, when you are doing your gynec and infertility scans, direction of the flow is not important to you. Most of the times you are looking at the capillary networks. You are not looking at single large vessels except when you are looking at the uterine. So don't worry about the direction. Just remember they indicate two different directions of the blood flow, red towards the probe, blue away from the probe. If that is the case, the flow which is perpendicular to the sound beam, it is not towards, it's not away, will not be shown on your color Doppler. It will not be shown on the color Doppler, though it is there. It is therefore that we need power Doppler. Power Doppler is a non-directional Doppler. Yes, it is true that as the name indicates power Doppler, it actually potentiates the Doppler effect of the sound beam. Let's not go into the physics, but it actually makes low velocity vessels visible. It makes low velocity vessels visible, and it doesn't tell you about the direction. So even the blood flow which is perpendicular to the sound beam will be seen clearly. So that is the practical application for the power Doppler. But now we also have what is called HD flow. HD flow is again a high resolution flow, but it also can show the directions, as you can see here. And the last thing is the spectral Doppler, is the graph that you get for the flow. that is called the spectral Doppler. That shows you the direction also, that tells you what is exact quantity of the flow also. The other two Doppler only tells you about the flow, it tells you about the quantity of the flow only subjectively. That means that the color which is brighter is high velocity, color which is darker is low velocity. It doesn't give you exact numbers. Spectral Doppler gives you exact numbers. Now coming to the color Doppler settings, the first thing is the gains, and remember that when the settings are done by the application specialist, even when you are doing your low velocity flow assessment, endometrium or the follicle, there should be no color spill outside the vessels. This is color spill outside the vessels. The gains, if this is the result, the gains should be decreased so that the color is contained inside the vessels fully. But if you decrease the gains further, you will not even see these vessels. If you decrease the gains further, you will not even see this vessel. See? Yes, so the gains have to be correctly set so that you see the vessels completely filled, no spill, but filling up the vessels completely. The second important setting is what is called PRF setting. And PRF is what? Pulse repetition frequency, or it may be scale on some of the machines. PRF should always be, I will not go into the physics again, PRF should be always related to the velocity. For high velocity flows, you need high PRF. For low velocity flow, you need low PRF. If you use high PRF for low velocity, though the flow is present, you will not see it at all. And if you are using low PRF for high velocity, that is when you will get mixing of colors or overlapping of the spectrum, which is called aliasing, So remember that the PRF must be set in a way that your diastolic flow, if you are seeing large vessels, the diastolic flow has to be unicolor. If you try the systolic flow to be unicolor, the diastolic flow will not be recorded. So that is how your PRF should be adjusted, but you don't have to use your abilities and brains here. You don't have to do any efforts here, because for all our infertility scans, as a rule, the PRF is set at 0.3. If you get flow at 0.3 PRF, fine. If you don't get flow, forget about it. Don't decrease the PRF. Similarly, gains, once they are set, are not to be changed for any of your infertility scans. For Gynae scans, the PRF is to be fixed between 0.3 and 0.6. You should not keep on changing it, because if you keep on changing it, you will never be able to compare one examination with the other. The third thing is what is called wall motion filter. The third thing is called wall motion filter. What is wall motion filter? Many a times when you switch on the color, you will have color and you will have white dots on it, what we call snow on the color. Have you seen that ever? Oh, sorry. I'm sorry. I was talking of balance. So what will happen is, see, you are seeing snow on the color, you are seeing that snow on the color, and now the color has disappeared. You are seeing it? This is normal. See, this is normal color, and this is snow on the color. This is snow on the color. Can you find out? Can you find the difference? Yes. So when you get overlapping of soft tissue details or snow on the color, that is when practical solution is to decrease the 2D gains. Don't touch the color gains, don't increase the color gains, decrease the 2D gains. And as soon as you decrease the 2D gains, you can see here, as soon as you decrease the 2D gains, increasing 2D gains and you are getting snow, and now decreasing 2D gains and you will see beautiful color. So that is the practical solution, but actually that is what is called a balance setting. I will not go into the details of the balance setting here, but there is one green line here seen on the gray bar, which works as a balance setting. If you want explanation on that, I will talk in the questions and answers. Coming to the last one, and that is the wall motion filter. We know that every moving object to which a sound beam hits creates change in the frequency of the incident beam and the returning beam. This effect is called a Doppler effect.
The Doppler effect reflects as color there, and the higher the velocity of the vessel, higher, that is what we talked about already, higher the vessel, higher is the Doppler, higher the velocity, higher is the Doppler effect, and higher is the Doppler effect, brighter is the color. Yes, lower the color, lower the velocity, lesser the Doppler effect, and dull will be the color. But those things, they also lead to unnecessary additional information on the image. You get color with the flow, you get the color with the moving vessel wall, you get the color because of the transmitted pulsations also. Yes, but you don't want the information of the wall moment, you don't want the information of the transmitted pulsations, and therefore if you put a filter which will filter out low intensity color flow, which is called wall motion filter, so that is also always put at the lowest. If that is also high, you will not document any low velocity flows. So there are four basic settings that you would require for the color and the power. When you are looking at the spectrum, you know this is the baseline. This is, in 5 minutes we will go for the live demos. So whoever wants to make some arrangements there. You have a baseline, you have the flow which is above is towards, the flow which is below is away from the probe. The spiky flow is the arterial flow, the flat flow is the venous flow. On the arterial flow, this is systolic, this is systole, this is the diastolic phase. This is the peak systolic velocity, this is the end diastolic velocity. Wherever the diastolic flow is more than 50% of the systolic flow, as you are seeing here, this is called a low resistance flow, where the systolic flow is more than 3 times the diastolic flow, more than 2 or 3 times the diastolic flow, we call it a high resistance flow. What are the settings important here? Your color the spectrum of the flow should always appear nice and bright like that, bold and clear. If your gains are more, you may have a lot of extra information, which is because of high gains. So whenever you get, it will come in a minute. I'll tell you this is wall filter, but let us see if it has also gains here. Yeah, this probably has gains. Yes, so if you get a picture like this, that means you have to decrease the gains. But if you decrease the gains too much, you will not get any information at all. This is low gains, that was high gains. So the gain should be set in such a way that you get a nice bold spectrum. The second important setting again is the wall filter there. As I told you, the wall filter filters out low velocity information, and therefore if you get a black line between the baseline and the spectrum, which should tell you that yes, the wall filter is high because the low velocity flows are not documented, this spectrum is never ever to be accepted, even if it is from the close friend, because that will give you a false impression that there is no diastolic flow. Actually, it is a high wall filter. So remember, the correct wall filter setting is that always the spectrum must touch the baseline, only that is acceptable. The third important thing would be PRF. Again there also, as I told you earlier, for high velocity flow you need a high PRF. What is the correct PRF setting? When the systolic peak covers at least 1/2 to 2/3 of the area dedicated for the spectrum. So if the peak is this high, I would be happy. But if I increase the PRF too much, not here, I don't know if I have that, I'll show you on the live. So if your PRF is too much, even the high velocity flows will not be seen. The high velocity flows are not seen, the diastolic flows will be seen very little. Therefore, you will lose the differentiation between the systolic and diastolic. So it must be always adjusted so that you can see the systole and the diastole clearly by making sort of a wall. So don't ask her to press down, ask her to press vertically so that the organs will not slide up.
ম্যাডামের সাথে ওখানে ফার্স্ট গ্রুপ কারা ছিল? ম্যাডামকে একটু চা খাওয়াতে হইতো না? হ্যাঁ, ওনাকে একটু না, এখানে তো দিবে, ওই বেবি রুমে নিয়ে যাও। সবাই একটু ধৈর্য ধরে বসেন, এখনই আমাদের লাইভ ডেমনস্ট্রেশন শুরু হবে। আমরা আসলে কাজের সুবিধার্থে কয়েকটা গ্রুপে ভাগ করে নিয়েছি। যারা ফার্স্ট গ্রুপে আছেন তাদের নাম এখন ডক্টর জেবুন বলবে। তারা আমাদের এই পাশেই কল্পস্কোপি রুমেই আসলে আমাদের এই ডেমনস্ট্রেশনটা চলতে থাকবে, আর আমরা এখানে স্ক্রিনে দেখব।
গ্রুপ এতে যারা আছে এখন ওরা চলে যাবেন আমাদের কল্পস্কোপি রুমে, এটা অনগোয়িং, একসাথে চলো। প্রফেসর শাহেনা আক্তার, প্রফেসর শিরিন আক্তার, ডক্টর আফরোজা ফেরদৌস, ডক্টর রওশন আক্তার জাহান, ডক্টর জেবুন্নেসা, ডক্টর আসিফ আলী, ডক্টর ফাহমিদা শিরিন, ডক্টর বনিতা বিশ্বাস, ডক্টর সাবিহা কাদের, ডক্টর ফাহমিদা ইসলাম চৌধুরী, ডক্টর সাইয়েদা ইয়াসমিন আক্তার, ডক্টর নূরজাহান বিনতে সাইদ, ডক্টর এটা কি সুনন্দা সেন, ডক্টর কামরুন নাহার, ডক্টর জাস্টিন ক্ল্যাম্প আর ডক্টর নার্গিস। সবাই আমরা এখন ইয়েতে চলে যাব 31-এর কল্পস্কোপি রুমে। এই গ্রুপের যাদের নাম আমি ঘোষণা করলাম।
এখানে আসলে 1.5 ঘন্টা লাইভ ডেমনস্ট্রেশনের মধ্যে 25 মিনিট সব গ্রুপে যারা পাবে, আর প্ল্যানারি এখান থেকে সব দেখা যাবে, ঠিক আছে। আর সোনোলজিস্ট যাদেরকে গ্রুপে ভাগ করা হয়েছে তারা ওইভাবে ম্যাডামের সাথে ওখানে দেখতে পারবেন।
আমি কালকে
Hello. Yeah. Okay.
এখানে যাদেরকে আমরা হ্যান্ডস অনে নিয়ে যাচ্ছি, আমি সকলের দৃশ্যে একটু বলছি। আপনারা সবাই জানেন যে এটা আসলে একটা সরকারি প্রোগ্রাম। সরকারি যে ফরেন ফ্যাকাল্টিসদের নিয়ে হ্যান্ডস অন ট্রেনিংয়ের একটা প্রোগ্রাম ডিজিএসে বা ডিজিএমইতে আছে। সাধারণত এই প্রোগ্রামগুলি ঢাকাতেই হয়, ঢাকার বাইরে খুব একটা হয় না। তা আমরা অত্যন্ত ভাগ্যবান যে এটা 3rd টাইম আমরা যে চিটগং মেডিকেল কলেজে এই প্রোগ্রামটা করতে পেরেছি, এবং এটার জন্য অ্যাসাইন আসলে 25 জন ডক্টর। কিন্তু আমাদের মনে হয়েছে যে এই সুযোগটা আমরা সকলেই উপভোগ করি, এই জন্য আসলে ওজিএসবি এবং ট্রেনি যাদেরকে আছে তাদেরকে আমরা ইনক্লুড করার চেষ্টা করেছি। আপনারা আমাদের এই ডাকে সাড়া দিয়েছেন, এজন্য আপনাদেরকে ধন্যবাদ জানাচ্ছি। তো যারাদের সরকারিভাবে নাম আছে আসলে তাদেরকে আমরা ওখানে হ্যান্ডসন একটু নিতে হচ্ছে, আর আপনারা এখানে আছেন, এই জন্য এটা মানে মনে করার কোনো কারণ নাই যে ওদেরকে এক্সট্রা বেনিফিট দেওয়ার জন্য নিয়ে যাচ্ছে। ওরা আসলে সরকারিভাবেই অ্যাসাইন্ড এই ট্রেনিংটা করার জন্য, যারা এখন ওখানে হ্যান্ডসনে গেছে। তারপরে এখানে আপনাদের একটু অসুবিধা হচ্ছে, এটার জন্য আমি দুঃখ প্রকাশ করছি। তবে আপনাদের কোঅপারেশন এবং ডেডিকেশন আমাদের প্রোগ্রামটাকে সাকসেসফুল করবে। আমাদের কিছুক্ষণের ভিতরেই লাইভ ডেমনস্ট্রেশন শুরু হবে। এর ভিতরে আমাদের সাথে শাহানা চৌধুরী ম্যাডাম আছেন, কারোর যদি কোনো প্রশ্ন থাকে ম্যাডামকে জিজ্ঞেস করতে পারেন। ম্যাডাম ইনফার্টিলিটির উপরে কি জানি মাস্টার্স ডিগ্রি করেছেন, তা আমরা সবাই জানি যে টিবিএসটা ইনফার্টিলিটির সাথে ক্লোজলি রিলেটেড। অতএব এই রিলেটেড কোনো প্রশ্ন থাকলে লাইভ ডেমনস্ট্রেশন শুরু হয়ে যেতে শাহানা আছে আমাদের সাথে। সনোগ্রাফির দুইজন স্পেশালিস্ট আছে, প্রফেসর আনিসুল মাওলা এবং প্রফেসর দিদারুল আলম। এর ভিতরে আপনারা কোনো প্রশ্ন থাকলে ওনাদেরকে করতে পারেন।
Yes, just 1 minute. Just 1 minute. Just 1 minute. Yeah, sit on this.
You understand English? You understand Hindi? Hindi ke English? English is fine. So come down. Okay. And then take your clothes up.
Just move a little bit. Please move a little. Once let me set my position, then you can come closer. Okay? Switch up. No, still. आओ नीचे आओ. आओ नीचे आओ. हाँ बस अब यहाँ से ना खोल दो. Give me. This is the indicator. Okay. So if you want to, one of you can hold my hand with this, so you know. Yeah, should be about. No, nothing. Thank you. Condom. Can somebody tell me the history of this patient, please?
Yeah, madam. Secondary subfertility due to RPL. Second
Okay.
trimester
So she has 2 second trimester losses. Okay. First delivery was normal. There are 2 deliveries. Okay. No. Delivery was normal, I'm asking. The first delivery, you said secondary, right?
she has no issue.
Oh, she has no issue. So both the times she had a pregnancy loss at 6 months, which is not very common to occur without a reason. And most likely it might be either adenomyosis or maybe a fetal cause. So again, starting from there, where we are seeing the symphysis pubis, and then we are seeing the urethra, and then we are seeing the bladder, then we are seeing the vagina here, anterior posterior wall and the air. We are seeing the anterior muscularis of the rectum. Gradually putting the probe in, and look, this hyperechoic dots are moving out because the air is going out. And as we go in, now we are seeing the bladder here. This is the peritoneal reflection on the bladder. And as we go in now, we are able to see the anteverted uterus, again not in the midline. I'm spanning the probe on the left side, I'm not seeing it. I'm moving it on the right side, I'm not seeing it. Why? Because here I am seeing the endometrium but not the cervix. So I only need to rotate the probe, and as I rotate the probe, now I am seeing the entire uterus. As I told you, see, there is adenomyosis because the uterus definitely appears large. Not only that it appears large, It also shows heterogeneity. Yes, if you bring it in the center, it does show heterogeneity. Can you appreciate that? Why do I say it is heterogeneity? You are seeing multiple tiny hyperechoic dots. You're seeing hyperechoic islands. And moreover, the posterior wall is much thicker than the anterior wall. So all those signs tell me there is adenomyosis. Apart from that, I would always want to, you have a better gray map? Just wait, okay. Let us set the focal zone. Focal, okay, this is better, this is better. So now you can see the junctional zone. Now you can see the junctional zone very clearly here in the lower part, but you can see that it is much more thickened up in the upper part, and it's also thickened and irregular here. That is again a very important sign of adenomyosis. This is one sign which otherwise can be seen only on your 3D sections or MRI, but you can also see it here. That means it is quite severe. From the midline, and moreover, there is one more important sign which is seen here. You can see that the endometrium, the fundal end of the endometrium is turning back. Otherwise the uterus is anteverted, but it is turning back, and this is what is called either a year sign or a question mark sign. And that is also, and yes, that is because of asymmetrical involvement of the endometrium, and that is also an important sign of adenomyosis. Now, once the uterus is in the center, I am going to span it onto one side. I'm not seeing anything, but it appears like the ovary is just by the behind the uterus, and it may also be adherent to the uterus. Onto the other side, I'm clearly seeing a bulge here. You're seeing a clear bulge here, okay? And that is a focal adenomyoma probably. Okay. Then going on to a part away from there, coming back, and you can see adenomyotic hyperechoic lines and dots there also in this area. Coming back, then we are also, we are going to turn the probe for the transverse section, and as we move it for the transverse section, as we move toward the fundus, we are seeing two cornu. We are seeing clearly two cornu, yes. So sorry, one is here and one is here. You're seeing one and here and one is here, and that tells you, yes. Can I improve the contrast a little? Contrast. No, that is frequency. Don't change the frequency. Don't change anything that it is otherwise okay. No, it's okay. Leave it. So you have that, you are seeing the two cornu, and from there, if I'm trying to move towards the right side, I'm not seeing any soft tissue adnexal band. If I'm not seeing any soft tissue adnexal band, which means the soft tissue adnexal band is bent towards itself, and therefore the ovary is likely to be posterior. And you are seeing that the ovary is seen posteriorly. Now, of course, I know that this is one ovary, but I'm not sure about what is this, because we know that with adenomyosis, there can be also endometriosis, and endometriosis can lead to hydrosalpinx also. So what, if we are not able to see that very clearly, the first thing I'm going to do is I'm going to change the focal zone. For changing the focal zone, yes, it does improve the visibility a little. And ye dukhta hai, pucho usko. Dukhta hai, hurts. No, this is paining. This. I'm pressing, it is not paining. Yeah. No, okay. So it is not hurting, so it's not less likely to be an endometrioma, but I still feel it is an endometrioma because this is a clot in the endometrioma, and that looks like a ground glass echogenicity, but we will confirm it. It might also be a hematosalpinx. Let's go on to the other side. Are we seeing the opposite ovary anywhere? No, we are beautifully seeing the cornu, both the cornu, but we are not seeing any soft tissue adnexal band on that side also. That means this ovary that we saw belongs to this, and not only belongs to left side, and not only that, as we scroll across the ovary, we are seeing multiple follicles. Here also we are seeing some ovarian calcinosis, but we are seeing here, this appears quite faint. I don't know why it appears so faint, but there is definitely a ground glass echogenicity here. If you can see a rounded ground glass echogenicity here, which probably is an endometrioma. See, it's a large endometrioma that you can see actually. There's a large endometrioma here we can see. If you put on the Doppler, ideally it may show you low it may show you short coursed vessels. Short coursed vessels are where the vessels they would come and approach is the can you switch on the power? So you would see you're seeing some vessels coming and approaching the wall, but they are not running along with the margins, and that tells you it is probably yes. Of course, the gains are too high there. I'm going to decrease the gains. So that is what you are seeing, short coursed vessels, which indicates yes, it is endometrioma. But I'm sure that she should have pain. Why is she not complaining of pain is a question for sure. Ye hurt karta hai. Dekho, now you can see it better. Yes, no facial expressions. And this is the opposite side. And there also, there is actually a huge endometrioma. Look at that. You actually are seeing it, just a second. As you increase the depth, see there is a large endometrioma there also. Yes, there is a huge endometrioma posteriorly, and both the ovaries are adherent to. There is a multiple endometriomas, and
Hello.
yes.
Hello, madam.
Yes.
Both ovaries
Adherent to the uterus posteriorly, kissing ovaries, and bilateral endometriosis.
Bilateral endometrioma.
Bilateral.
Can you see this one bilateral?
Yes, it is very common.
Oh,
Very common.
Follow korte participate na audience.
Very common. And see, you are beautifully now seeing the question mark sign also. Yes?
Yes.
So that is it. And if anything else?
Madam, show the junctional zone.
Junctional zone is, I showed you here, it is absolutely irregular in the upper part. In the lower part, it is very clear, as you can see here. Yes, but in the upper part, it is completely irregular. As you can see here, this is completely irregular, and it is traversed by hyperechoic strands, which is the endometrial strands, and here in this area, it appears clearly irregular. So that is the junctional zone abnormality.
Madam, which is the days of menstruation? Because internal os, UC, uterocervical canal.
You are seeing the hypoechoic cervical glands, and there are multiple nabothians. And if you increase the angle a little, now you are seeing the entire cervix. You are seeing it right from the internal os here to the external os there.
And cervix is a bit open.
Cervix is not open, ma'am. Cervix is not loose. If you at all want to, then you have to go to a higher modality, which is called cervical elastography. So if you do an elastography, you can actually assess the firmness of the cervix, and that will tell you whether it is because of cervical reason or not. But the thing is that would only be appreciated best after pregnancy, not now.
Yes. Anyone? Madam said the elastography, cervical elastography.
No, the endometriosis size is not important. Yes, it is true that when you want to decide for the surgery, if the lesion is more than 5 centimeters, you usually plan for a surgery. When it is less than that, you may or may not plan for the surgery. If you ask our practice, if the ovaries are adherent like this, there is a 100% chance that the tubes and the tube-ovarian relationship is affected. But if there is a small endometrioma and the ovary is seen far from the uterus, we would always prefer to do what is called either a hycosi or a saline infusion sonography and confirm the tube is patent or not. If the tube is patent, we would try 2 or 3 cycles of IUI, good IUIs, but if then patient doesn't conceive, we would advise for a laparoscopy. Because it's not just the patency of the tubes which is important, you also need to see that the tube-ovarian relationship is normal. Even if the tube is patent, but the tube-ovarian relationship is not normal, the chances of pregnancy is very little.
Madam, can you say why she had losing the Mid-trimestral loss. Is there any cervical
There
incompetence?
is no cervical cause, madam, but that cervical cause can only be seen if it is loosening of the cervix can only be seen after pregnancy, ma'am. Here the cervix is very long and nice. Say if I measure it, it is.
Can
I
you
want
see
a
this
trace.
one? How to measure the cervical length?
Yes, just minute, ma'am. So if you can, yeah, it may be because of adenomyosis. That is very much likely.
Maybe common adenomyosis causes cervical pregnancy.
And it always causes second trimestral losses. So that is the length of the cervix, ma'am. Without pregnancy, it's very good length, no problem.
Yes.
No, there are no adhesions there. Cervical length, cervix is not adherent. Ovary is adherent, posterior to the body. Cervix is not adherent. The length is not because of cervix adhesions. Okay, the next one here.
না কেউ যদি চায় যে সার্ভাইকাল ইনকম্পিটেন্স কি না হয় the woman has cervical incompetence এটা তো in between pregnancy we can say by
So
Hagar
in between
test.
pregnancy, ma'am, you can see the elastography, or you have to. So you have to assess the elastography, but here there is no incompetency seen because there is no funneling. The cervix is long.
Yes,
So
ma'am.
it's nothing that is nothing.
Not only by ultrasonography and elastography.
Yes.
Those have a facility not like this. You can do the Hagar test.
Yes.
আমাদের নেক্সট বিবেচে যারা আছে তানজিলা করিম, সোহেলা শাহনাজ, ফাহমিদা রশিদ, শাহনাজ জাহান চৌধুরী, মনোয়ার সুলতানা, জিনাত রেহানা, নাজদিন আহমেদ, রশনারা শিমুল, ফরিদা ইয়াসমিন সুমি, শাহানা বেগম, উম্মে হানি, মীনাক্ষী রয়, জান্নাতুল মুকিম সুপ্তি, ফারজানা মাহমুদ জ্যোতি, সোহেলি আক্তার, তাসলিমা বানু। আপনারা সবাই ঠিক sharp at 11 ওই
I want
পাশের
your
রুমে যেটা কল্পস্কোপি
grey
রুম
map.
ওখানে চলে
Grey
যাবেন
map.
sharp at 11
Gray map.
ma'am can you demonstrate the anterior and posterior compartment of the compartment?
I will try to, but probably all the settings are not as I would like them to be, but yeah, we are trying to get to better ones. You're seeing the symphysis pubis here. You are moving in. We are seeing the bladder. We are seeing the bladder here. I am seeing the.
Ma'am, can you stay a little bit in the place that you are demonstrating just
Yes. So
understanding?
this is symphysis pubis. You are seeing the bladder here. Gently introducing the probe in. There is some air probably in the probe, so I will just rub the probe against the vagina a little to remove that air. Come back, but it's still there.
You are still in the vagina, right, ma'am?
Sorry?
In the just
No,
cross the
I will come back here.
Okay,
See now, you are seeing symphysis pubis, urethra. You are seeing the bladder here, anterior wall, posterior wall of the urethra. You will observe the sliding between. I will decrease the depth, and we will see the sliding between the vagina and the urethra. Okay, and then we will angulate the probe slightly posteriorly to see the bowel, because you want to see the posterior compartment. We would angulate the probe posteriorly. You are seeing here the rectal lumen. You are seeing the anterior muscularis, and I'm going to move the probe. Beta, thoda niche aa sakte hain? Thoda niche.
Ma'am, what does it signify,
niche.
sliding of the urethra and vagina?
Yes. You want to see it again?
No, what does it signify?
It signifies that there are no adhesions there, and therefore probably no anterior compartment involvement, if at all there is endometrium. So no adhesions there. So anterior muscularis, posterior muscularis of the bowel, and we would gently want to introduce the probe in. And as we are moving the probe
I am
in,
requesting all of you to be silent, please.
as we move it in, we are now seeing the bowel further. We are going to trace it down.
Bowel means rectum means what?
Yes, we are going further deeper to evaluate the muscularis, going deeper. You're seeing this muscularis where my arrow is moving. You're seeing going further down in. You're going further down in. You're seeing this muscularis still. The bowel is now, so you are going towards the flexure. You are seeing now, you have rotated the probe to match the curvature of the bowel.
You're seeing it here, seeing it here, seeing it here, and you have almost reached the fundus of the uterus, and the fundus of the uterus is the sigmoid colon. And beyond that you cannot see the rectum vaginally, the bowel vaginally. So that is how you would trace the bowel. Let us first come to the center, and so that was just to show you how to trace the bowel. Beta pair khule rakho please, pair khule rakho aise. You are again out, going in. There's a lot of air again in the probe, and so in the between the probe and the vagina, between the probe and the condom. So that is the reason probably the visibility is a little poor. I'm decreasing the depth, and if at all required we would change the condom. But we are going in the center, we are right in the center, we are not seeing the uterus at all. Not seeing the uterus, so we are going to span and see the uterus is completely deviated onto the right side, on the left side. And not only that, you are seeing a very hyperechoic, you are seeing a very hyperechoic endometrium. Not only that, you are also seeing some calcifications inside the endometrium, and as you span from one side, you are also seeing a tiny fluid loculi. Did you see that? There's a tiny fluid loculi. The loculi is a very clear sign of a synecdoche. So there is calcification and there is also synecdoche. This is absolute assurement. There is no other doubt in this. So anything else that you want to see on that? Okay, from the midline, as you are moving to the side, you are seeing the uterine artery coming in. And as you see the uterine artery coming in, you would also see its bifurcation. But I'm going more laterally. So I'm going laterally. I'm from the midline going laterally, and as I'm going laterally, I will see the uterines coming in. And as you put on the Doppler, let's increase the PRF, let's increase the scale. Okay, so just wait. So as I'm increasing the scale to reduce this turbulence or aliasing, because uterine usually has a high resistance flow. So I will measure the flow in the uterine once the uterine has entered into the uterus, but it is still not bifurcated. When you are measuring the flow in the uterine, you are only concerned about the PI or at the most the
Hello,
RI.
madam.
And when it is about PI and RI, that is when angle doesn't matter. The angle is important only for PSV and diastolic flow, and therefore we don't need to adjust the angle. Even if it is perpendicular, you can still get the flow parameters. Just go to auto calculation.
Hello, madam.
Oh, it's already
Madam, one
there.
question, please.
Yes, ma'am.
Madam, please, what about the probe position when you are measuring uterine?
It is longitudinal.
Longitudinal, not transverse, madam?
No, not transverse.
No. Thank you.
Because on the
At the
transverse, you will not know where.
Can you please mention the level where I should put my probe, madam?
You have to see, you are in the midline. You are in the mid-sagittal plane of the uterus.
Yes.
Span the probe laterally.
Yes,
As
madam.
you span the probe laterally, you will see anechoic structures entering inside the uterus. You're seeing that?
Yes, madam.
If you, once you start seeing that, put on a Doppler. That will tell you where are the vessels which are of which are larger vessels. Go further laterally. Okay?
Okay,
Till you see the uterine wall. If I go more farther than this, I am losing the vision of the uterine wall. The morphology of the endometrium appears normal. I think it is probably the follicular reason, but right now the follicle is also not mature, so it is difficult to say that the reason is in the endometrium or not. Let's see the opposite ovary also. This ovary has a good follicle actually. We will measure the size of the follicle.
Is it a stimulated cycle, ma'am?
Get me the another one. Huh? Okay.
So the follicular size appears to be like, I would always want to measure the, I would also always want to measure the follicle again, just like the ovary, in 3 diameters. The longest diameter perpendicular to the long diameter, and the largest transverse diameter, and the mean of that is my follicular size, and that comes to about 13.5. That comes to close to 13.5. So that is not yet a mature follicle, but if it is a growing follicle, if it is not a bad follicle, it should ideally show some flow. Look at that. It does show some flow. I need to probably adjust this, and we need to also see, you're seeing flow surrounding that follicle of 13, 14 also. So that tells me, yes, there is definitely, that is a growing follicle. Remember that the follicle, not only when it gets mature, even when it is a growing follicle, it is a dominant follicle, it will show you the flows. So there needs the PRF to be set. PRF. No, let of course decrease, because you're not seeing the flow there, isn't it? So let's just go back and do it once again before I by chance move my hand. See, you're seeing nice flow, and there, as I told you, the direction doesn't mind, because you're seeing the flow in the capillary network. You are not seeing the flow in a single vessel, you know. So it is, just do a manual trace. So it is very important. And no, I don't want auto trace. I want a manual trace of 1 cardiac cycle. No, it's not just the velocity trace. I want to trace it, and I want to know the RI of it. Just do RI. You're not getting it. No, RI cannot be measured there. It is to be measured from the end diastolic till end diastolic. That's how you would measure the RI. And it comes to, no, that is not right. That is not right. It is not 0.9. This is less than 0.6 for sure. So give me a manual trace. Can you not do a manual trace there? So I'm sorry, but we will not waste time there. But you can clearly see that it is a low resistance flow. If you still want to maybe get a better flow trace, we will. Cyst will never have a flow. Cyst will never have a flow, and it is only 13 millimeters. I told you, you always should correlate it first with the physiology, isn't it? See, you are seeing beautiful follicular flow. So that means it is definitely a growing follicle. It is 13. I would tell you, I would request you, see, because there is a cervical mucus also, the endometrial margin is very clear. The junctional zone is also quite intact. So I would think that if you get a better quality follicle, you will definitely get a good endometrium in that too. Let us also check if we have any endometrial vascular